On behalf of those present, I acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the land on which we now meet. I pay my respects to their elders, past, present, and emerging. I also pay my respect to all Aboriginal and Torres Strait Islander people of Australia and hope that the path towards reconciliation continues to be shared and embraced. The main etiology of COVID-19 is caused by acquiring the virus SARS-CoV-2, which is commonly spread through close contact with another person. The virus can spread through an infected person's mouth or nose in small liquid particles when they cough, sneeze, speak, sing, or breathe heavily, with the liquid particles ranging from larger respiratory droplets to smaller aerosols. The World Health Organization states that aerosol transmissions can occur in specific settings, particularly in indoor, crowded, and inadequately ventilated spaces, where infected people spend too long periods of time with others, such as restaurants, fitness classes, offices, to name a few. While some people can catch COVID-19 when the virus is directly transferred into their mouth, nose, or eyes, other people may acquire the virus when they touch surfaces that have been sneezed, coughed, or touched on, such as tables, doorknobs, and handrails. Following this, they fail to clean their hands. These events often occur when people are in direct contact or close contact with each other, which is described as less than 1 metre apart. Thus, governments worldwide have implemented strategies to encourage hygiene habits such as staying 1.5 metres apart and constantly washing hands to help reduce the spread of the virus. It is important to understand that viral transmission factors include incubation period, reproduction number, serial interval, secondary attack rate, viral load, and shedding.
The pathophysiology and disease progression of COVID-19 is facilitated through three stages: initial viral infection of host airway epithelial cells, upper respiratory tract, and lower respiratory tract invasion and infection. To understand the pathophysiology, it is important to initially consider the viral structure. Coronaviruses are a large, positive single-stranded RNA virus which is made up of four structural proteins: the spike, membrane, envelope, and nuclear capsid. As seen, the S protein protrudes from the viral surface, and this facilitates the initial virus attachment and penetration into the host cell. As Tom explained, the viral particles are received through transmitting processes which travel through the upper respiratory tract and for 1/5 of patients reach the alveoli. Along this pathway, there are several epithelial cells which contain a surface protein known as ACE2, which is a functional receptor for the S protein of the virus, acting like a lock and key mechanism for viral host cell invasion. Post-membrane fusion, the viral single-stranded RNA penetrates and hijacks the host cell's transcriptional machinery to initiate viral genome replication. The new viral particles then undergo exocytosis out into the extracellular space, reassemble, and are now ready to invade and infect the adjacent cells. Infection of the upper respiratory tract will see manifestations of symptoms of a fever and a dry cough, although for 4/5 of patients, the immune inflammatory response will suppress the virus from progressing to the lower respiratory tract, although patients are still highly infectious. For the 1/5 of all infected patients that will have the virus invade the type 2 alveolar epithelial cells, the virus-loaded cells will now release several cytokines and pro-inflammatory markers to fight off the virus. A continued inflammatory response results in alveolar interstitial thickening, vascular permeability and edema, impairing the process of gas exchange, and can culminate in pneumonia and acute respiratory distress syndrome. The increase in vascular permeability may also result in systemic inflammation, which can cause septic shock, and an influx of cytokines in the bloodstream will travel towards the hypothalamus, inducing a raising of body temperature. This attracts T cells, but this consequently results in inflammation and further lung damage through host cell apoptosis, allowing the release of new viral particles which propagate the infection. To aid in the understanding of the impact COVID-19 can have on an individual, it is important to recognise that the sequelae effects of the pathophysiology span across physical, psychological, and social domains of health. Therefore, I've incorporated the use of two domains, participation restrictions and activity limitations, to assist in providing a coherent view of COVID-19's impact on an individual. As I previously referenced, the pathophysiology of COVID-19 is progressive and dynamic. Therefore, it is important to express that the listed consequences provide a general overview of presenting problems. Participation restrictions, referring to an individual's involvement in everyday life situations. Due to illness, fatigue, and an infectious state, COVID-19 patients are unable to attend or in severe cases undertake work or schooling requirements, or participate in social events, sport, and hobbies. As for activity limitations, referring to the execution of tasks at an individual level, literature has shown due to low physical functioning, COVID-19 patients have a reduced exercise tolerance, along with impaired ADL and PADL measurements on hospital entry and discharge, these being mobility, transfer, ascending and descending stairs, feeding, personal toileting, and bathing.
Depending on the severity of the condition, the subjective and objective examinations and findings will differ. For an individual testing for the identification of COVID-19, subjective screening questions on the slide will be asked. These questions are relevant as patients commonly report symptoms such as fever, cough, shortness of breath, chills, body aches, sore scratchy throat, headache, runny nose, muscle pain, vomiting, nausea, diarrhea, or loss of smell or taste. Objectively, a temperature test would be taken to identify whether they are above 37.5 degrees, which is consistent with having a fever. For a patient in ICU due to COVID-19 progressing to a secondary respiratory concern, the role of the physiotherapist would be required to identify areas of concern with the patient. The subjective findings would be identical to those found in the COVID-19 screening. However, objective findings may display increased oxygen requirements, fever, difficulty breathing, frequent severe or productive coughing episodes, and changes in lung consistent with consolidation found in chest X-ray, CTs, or ultrasounds.
This slide outlines the evidence, asterisk signs, and assessment for the physiotherapy problems associated with acute COVID-19 infection. Impaired gas exchange is the inability for the respiratory system to adequately provide for systemic metabolic requirements, hence rendering it the most important cardiorespiratory problem associated with COVID-19. Due to the perfusion of poorly ventilated alveoli and hence VQ mismatch and reduction in functional residual capacity, COVID-19 affected patients have increased carbon dioxide and decreased oxygen levels, causing impaired gas exchange. Low lung volumes reflect an inability for individuals to use tidal volume and all of their vital capacity due to alveolar interstitial thickening and in turn edema. This further limits the ability of the respiratory system to adequately remove carbon dioxide from the blood. And this situation is made worse by an increase in carbon dioxide as a result of increased metabolic demands, thus rendering this problem quite important. Impaired airway clearance is the inability for individuals to remove sputum from the airway. Acute COVID-19 causes changes in secretion quantity and quality resulting from the acute infection. Patients are also unable to clear their airways of sputum due to poor cough mechanics associated with ICU-acquired weakness. Excessive sputum retention may cause bronchiectasis, which can be fatal, thus a high priority problem to be addressed. Due to edema and airway wall thickening, respiratory rate is likely to increase to counteract this difficulty. Accessory muscles will also be recruited. Depending on the severity of the thickening, this may cause bronchiectasis, which can make it hard to breathe. Thus, this is a critical problem associated with COVID-19 infection. Acutely ill COVID-19 patients are likely to have decreased mobility due to the pathophysiology associated with the disease, and potentially due to ventilator oxygen therapy. Laying supine can further accentuate reduction in lung volume, thus a marked problem of COVID-19. Dyspnea is the perception of the patient of breathlessness. The patient is feeling this due to loss of hypoxic pulmonary vasoregulation, leading to VQ mismatch and hypoxemia. Also due to increased mechanical load on inspiratory muscles and adaptation of ICU-acquired weakness. The body aims to reduce the excess carbon dioxide due to the mismatch by increasing minute ventilation, which is the product of respiratory rate and tidal volume. This is achieved by increasing the respiratory rate. Depending on the level of respiratory rate increase, the severity of this problem may range. Acute COVID-19 patients suffer from decreased mobility and decreased exercise tolerance. Due to these problems, COVID-19 sufferers may experience muscle contracture and or elasticity, which poses its own physical challenges. This problem is important and highlights the need for mobility.
On this slide here, we can see the current consensus developed for physiotherapists to follow when treating COVID-19 or suspected COVID-19 patients. ACPTs aim to improve the recruitment of alveoli, therefore improving respiratory drive and mobilization of sputum, resulting in increased ciliary motility and a reduction in sputum retention. It is performed in 2 stages: relaxation of airway through thoracic expansion and forced expiratory time. The method to perform this can be seen on the screen. Non-invasive ventilation is aimed at improving lung volumes and sputum clearance. It must be recognised that this method significantly increases aerosolization of particles and must be cleared by the senior medical doctor. CPAP therefore aims to improve gas exchange and improve lung volumes in patients suffering from hypoxemia or VQ mismatch. It provides a constant pressure on both inspiration and expiration, forcing airways open. It must be noted that CPAP should only occur to a maximum pressure of 10 centimeters of H2O and 60% oxygen. Currently, high flow nasal oxygen is not recommended for use in Australia. The supine position reduces lung volumes and can result in consolidation and perfusion ventilation mismatch. Research shows that positioning is an essential practice in COVID-19 patients as they are at increased risk of bacterial infection due to intubation. Prone positioning with percussion is shown to improve homogenization of the lungs, leading to improvements in lung volume and ventilation. Current research suggests that a threshold device for respiratory muscle training with low resistance be implemented, pressure beginning at less than 10 centimeters of H2O. It should be performed for 30 breaths 2 times a day, with training effects typically seen after 4 weeks. This method of training should be performed for both inspiratory and expiratory muscle training, as there is a residual deficit seen in either or both breathing cycles. Early mobilisation is strongly suggested in counteracting the effects of ICU-acquired weakness, as outlined above. Current evidence shows that this is safe and is strongly associated with improvements, as shown on the slides. Future research into COVID-19 and early mobilisation is currently underway, with the direction focused on in-bed cycle ergometry, with this hypothesised to reduce the effects of sarcopenia, respiratory-related motor impairments, and muscle atrophy.